Respected judges and dear friends, a fine good afternoon to you all. Today I'll be talking about my study. It's a study of optical coherence tomography parameters in diabetic retinopathy. There is an emerging body of evidence which suggests that diabetic retinal neurodegeneration precedes microvascular complications in diabetes, and it can be quantified by measuring the retinal layer thickness. The rationale for my study is, if we can prove that if there is a thinning of retinal layers, it constitutes a great evidence that diabetes accelerates the age-related loss of ganglion cell inner plexiform layer. And indeed, neuropathy occurs before vasculopathy. Materials and method. My study was conducted in the Retina Clinic, Department of Ophthalmology, Government Medical College, Thrissur. It was a hospital-based cross-sectional study. Study duration was for a period of 1 year. My study population include patients with type 2 diabetes mellitus and age and gender matched non-diabetic patients attending the ophthalmology OPD. Inclusion criteria. Patients were divided into two groups. That is, group 1 include diabetic patients. They may have no diabetic retinopathy. They may have mild diabetic retinopathy or moderate diabetic retinopathy. And the group 2 include non-diabetic patients. They were age and gender matched. Exclusion criteria: patients not giving consent, not cooperative patients, extremes of age, changes of cystoid or spongiform macular edema on OCT, advanced diabetic retinopathy changes, who have undergone cataract surgery, history of macular laser photocoagulation. According to the study conducted by Hyung Bin et al., the sample size was detected to be 30 eyes in group 1, that is patients with diabetes, and 30 eyes in group 2, that is non-diabetic controls, and a total sample size of 60 eyes. Study procedure: after an informed written consent, detailed history and complete ophthalmological evaluation was done. Heidelberg Spectralis spectral domain OCT machine was used to measure the thickness of the retinal layers. Inbuilt Heidelberg Spectralis auto-segmentation software was used to identify the ganglion cell inner plexiform layer and inner retinal layer thickness. This is the auto-segmentation software we used. The measurements were taken 1.5 millimeter from the fovea. Statistical analysis was done using chi-square test and Mann-Whitney U test. Coming to the results, the demographic showed that age and gender was indeed statistically comparable between two groups, and the mean duration of diabetes was 7.6 years. And in group 1, there were 16 patients with no diabetic retinopathy, 12 patients with a mild NPDR, and 2 patients with moderate NPDR. Now coming to retinal layer thickness, we saw a drastic change in the retinal layer thickness between the two groups. Compared to the group 1, that is non-diabetic controls, the ganglion cell inner plexiform layer was 92.3. The average was 92.3 in group 2, that is non-diabetic controls, compared to a staggering low 76.6 micrometer in group 1. Similarly, inner retinal layer thickness was a 247, a robust 247 in group 2 compared to 220 micrometer in group 1. Discussion. So, a significant reduction in the GC-IPL and IRL thickness were noted, thus confirming that diabetes is indeed an accelerating factor for retinal neurodegeneration. My study is in agreement with Hyung Bin et al. Study, which showed progressive thinning of GC-IPL layers. Eliot et al. Confirmed progressive inner retinal layer thickening preceding the clinical stages in diabetes. This is a short diagram to show you what is happening in diabetic retinal neurodegeneration. There occurs various pathways resulting in oxidative stress, glutamate excitotoxicity, finally resulting in neuron death and glial dysfunction. Conclusion. Ganglion cell inner plexiform layer in inner retinal layer thickness are markedly less in patients with diabetes compared with the normal controls. So, OCT can serve as an important predictive tool in the detection of early diabetic neuronal degeneration. Limitations of my study include an absence of metabolic correlation with retinal layer thinning, a small sample size, and confounding factors like hypertensive retinopathy. These are my references. Thank you.
Yeah, that was a good presentation.
Thank you, sir.
So, how did you decide on the sample size?
It was deducted statistically from my parent study, which used about 132 patients. It was a prospective study. So from that, when we extrapolated into our settings, we got 60 eyes.
Okay, you used a formula based on the previous one, or you just use the same sample size that they used?
Formula based statistically deducted.
Okay. Why did you exclude macular edema from your?
I want to, the study's aim was to see early diabetic changes, that is before maculopathy, vasculopathy sets in. We wanted to see whether there is neuronal degeneration in diabetic patients compared to non-diabetics.
So vascular changes would be there in diabetic retinopathy.
Yeah.
And you included them in group 1.
Only where the macula was there is no macular edema.
Yeah, that's my question. Yeah. So why did you exclude macular edema but did not exclude diabetic retinopathy?
Macular edema, we were looking for the macular layer GC-IPL thickness.
Yes, correct. That's what I wanted. Thanks. Good.
Good afternoon, everybody. I am here to present my paper on screening of retinopathy of prematurity, a comparison between binocular indirect ophthalmoscopy and RETCAM 120. Retinopathy of prematurity is a disorder of development of retinal blood vessels in premature low birth weight infant, and it is one of the major causes of preventable childhood blindness. The increase in incidence of ROP in India is because of the increase in premature birth rate coupled with advancement in neonatal care leading to higher survival rate of premature infants. Early detection and timely intervention can reduce the burden of disease, and also it has a huge medical legal implications. If a child goes blind due to missed ROP, both the ophthalmologist and pediatrician are at high risk of getting into a lawsuit. The conventional and gold standard method for ROP screening now is the binocular indirect ophthalmoscopy, but the problem is that this technique requires an ophthalmologist who is experienced and trained in ROP screening, which is lacking in many of our regional hospitals. In this context, digital retinal imaging using RETCAM is emerging as an important tool for ROP screening. By this, pediatric ophthalmologist service can be extended to remote areas by electronic transfer of images captured by trained paramedical staff. And also, this digital imaging gives a photographic record for the future purposes. This study aims to compare the efficacy of RETCAM 120 to binocular indirect ophthalmoscopy in screening of retinopathy of prematurity. Study design was a diagnostic test evaluation. Study setting. Study was conducted in ROP clinic and neonatal ICU at Government Medical College, Thrissur. Study population included infants registering under ROP clinic of Department of Ophthalmology at Government Medical College, Thrissur as per pediatrician's advice, and the study period was 1 year. The study included infants with birth weight less than 2000 grams at or post-conception age less than 34 weeks, and these infants were examined 4 weeks postnatally or at post-conceptional age 31 weeks, whichever is later. Post-conceptional age was determined by the neonatologist based on the last menstrual period. Infants whose parents did not give consent for the study, poor media clarity affecting satisfactory fundoscopic imaging and examination, infants with poorly dilating pupil and poor quality images were excluded from the study. Sample size was calculated using this equation and was found to be 80 eyes. Study tools included binocular indirect ophthalmoscopy at 20 diopter lens, RETCAM 120. The study used Forest Trinetra Neo, lid speculum, scleral indenter, and dilating drop, that is 0.4% tropicamide plus 2.5% phenylephrine eye drops, and topical 0.5% proparacaine drops as the topical anesthetic. Study procedure. First, the post-conceptional age and birth weight of each infant were recorded. Then the pupils of each infant were dilated and examination carried out after 1 hour. At first, RETCAM examinations was carried out and a series of photographs were taken using RETCAM 120 to adequately capture the posterior pole and periphery as much as possible. And then the fundus examination carried out using binocular indirect ophthalmoscopy and a 20 diopter lens with scleral indentation, and ROP changes were recorded. The data obtained by both these examinations were compiled and tabulated according to international classification of ROP. Coming to the results, ROP was detected in 52 out of 80 examinations carried out using indirect ophthalmoscopy and 38 out of 80 examinations carried out by REDCam. 14 REDCam examinations were false negative and 1 was false positive. This table gives a comparison between clinical and REDCam examination finding. From this, the sensitivity of REDCam was found to be 73.07%, specificity was found to be 96.42%, positive predictive value was calculated to be 97.43% and negative predictive value was 65.85%. Coming to discussion, the ROPs which were missed on REDCam examination were mostly located in zone 3 or anterior zone 2, which regressed without any treatment. No case of any threshold ROP or ROP in zone 1, ROP which later required treatment were missed on REDCam examination. This table compares the study with other similar studies, and here we can see that the values obtained from this study is almost in agreement with the values obtained by other studies. The study conducted by Caroline Wu et al. Considered only the pre-threshold and threshold ROP, and the sensitivity was found to be 100. No case of pre-threshold and threshold ROP was missed in the above study, and the case which was detected to be false positive in this study was due to an imaging artifact. Thus, we can conclude that examination by indirect ophthalmoscopy remains as the gold standard and should be used as a screening tool for ROP where there are sufficient trained personnel available, and also in situations where REDCam images remain indeterminate. But in remote areas where the service of a trained ophthalmologist is not available, telescreening using REDCam is a suitable alternative. And the study recommends the use of REDCam as a screening tool for detecting ROP in peripheral hospital to identify the referral warranted cases, and adequate training of staffs must be assured before employing them in digital imaging. These are my references. Thank you.
Yeah, nice presentation. Was the same examiner doing both the procedures one after the other?
Yes, sir.
And it was one examiner for the entire, for all the children. And the order was the same? Always REDCam before?
First REDCam was REDCam examination was done, which was followed by indirect ophthalmoscopy.
So, in your study design, do you would you envisage any problem with that kind of design? If always REDCam is done before, when you're comparing two procedures and one is done always before the other, can that affect the interpretation of results?
First doing indirect ophthalmoscopy, I thought it would manipulate the results.
It could be either way. So a better design would be to alternate between the two, mix and match. You randomize that, which comes first.
Okay.
So in your case, before indirect is being done, you've already evaluated all of them by REDCam. So indirect gets an advantage in the sense that you're going second. Okay, thank you.
Thank you, sir.
So you say that you're saying that indirect is any day better than the REDCam, is it? That's what you said in your conclusion.
For better visualization of the peripheries, that is possible with indirect, but not so convenient with REDCam examination. Visualization.
Good afternoon. Title of my paper: Comparing Peripapillary Retinal Nerve Fiber Layer Thickness and Visual Field Changes in Primary Open-Angle Glaucoma and Normal Eyes. Glaucoma serves the second leading cause of blindness in the world. Significant loss of ganglion cell occur before identifiable cupping and visual field defects. RNFL loss precedes measurable optic nerve head and visual field damage. OCT is a non-invasive method of determining RNFL thickness and focal defects. Thus, OCT RNFL thickness helps in early detection of glaucoma. Aim of my study: comparing peripapillary retinal nerve fiber layer thickness and visual field changes in primary open-angle glaucoma and normal eyes. This was a study done in patients attending ophthalmology OPD at Government TD Medical College, Alappuzha. Study period is 1.5 years following approval. In POG patients, I included patients diagnosed with POG with age less than 70 years, open angles, refractive errors with myopia less than -5 diopter, hypermetropia less than +3.5 diopter, and astigmatism less than 2 diopter. In normal subjects, patients with refractive error less than 4 diopter, with no history of glaucoma, IOP less than 21, no visual field defects, normal fellow eye of patients with cataracts, and attendance of patients who have no evidence of glaucoma or family history of glaucoma. Then sample size was calculated from the parent study as 20 per each group. Data collection procedure. After detailed history and preliminary examination, peripapillary RNFL thickness measured from OCT of both normal and POEG patients. All subjects had undergone visual field testing with Humphrey field analyzer, and they are classified into subgroups of glaucoma by Hodap's classification. RNFL parameters for these glaucoma subgroups and normal subjects were compared. Then independent t-test, f-test and chi-square test was done. P-value less than 0.05 was considered to be statistically significant. Statistical analysis were performed using a statistical software package SPSS20. Results: 40 eyes, 20 normal and 20 glaucomatous eyes were studied. The mean age of glaucomatous eyes was 55.9 plus or minus 10.7 and normal was 39.8 plus or minus 9.7. RNFL thickness was greater in superior and inferior quadrant than nasal and temporal in normal eyes. On comparing the average RNFL thickness, it is found to be high in normal control, that is 98.8. In glaucomatous field loss, that is found to be decreased, that is 74.2. On comparing superior RNFL thickness, it is found to be high in normal control, that is 122.2. In glaucomatous subjects, it is found to be 92.1. On comparing the inferior RNFL thickness, it is also found to be high in normal control, that is 131. In glaucomatous field loss patient, it is found to be 91.5. A similar trend was also observed on comparing nasal and temporal RNFL thickness. The average RNFL thickness was also found to be high in early glaucomatous field loss patient, than moderate glaucomatous field loss patient, and than severe glaucomatous field loss patient. A similar trend was also observed on comparing superior and inferior RNFL thickness. Discussion. This study compared OCT RNFL thickness with visual field changes in POEG and normal eyes. That is, here association between functional and structural findings was compared. Peripapillary nerve fiber layer thickness shows significant reduction in glaucomatous eyes in average value and quadrant-wise values. In our study, those having early glaucomatous field changes by Hodap's classification even shows thinning of average and quadrant-wise peripapillary retinal nerve fiber layer. Thinning of RNFL was more for eyes with severe glaucomatous field loss, which is more than moderate field loss, and which is more than early glaucomatous field loss. Conclusion. OCT peripapillary RNFL thickness measurement serve as an accurate and sensitive diagnostic modality for detection of POEG. It is effective in predicting RNFL thinning than visual field changes. By direct investigation of peripapillary RNFL, early diagnosis and detection of glaucomatous progression become possible. And this was my references. Thank you.
Thank you. Why did you exclude those refractive errors?
Because with high refractive error, it can, in visual field detection, it can have some negative association.
In the visual fields?
Yeah.
Okay.
And also with high myopia, it can have some effect on RNFL, peripapillary RNFL.
Okay. Isn't this a known fact already before you did the study?
Yes, it was found out in many studies, but now also visual field is being more considered than OCT RNFL in detecting glaucoma. Studies are going on.
Okay. Yeah, thanks.
Thank you.
Good afternoon, everyone. My topic is the pattern of refractive errors in children of age group 3 to 12 years attending a pediatric ophthalmology clinic in a tertiary eye care center in South Kerala. No financial interest. Now, the refractive errors are the second leading cause for treatable blindness in the whole world. It is also one of the most common problems causing visual impairment in school-going children. With the advent of COVID-19, there has been an increase in the use of on-screen devices, hence a possibility in the rise in the burden of uncorrected refractive errors in children. So the aim of our study was to analyze the pattern of newly detected refractive errors in children of age group 3 to 12 years. So our study was a retrospective study conducted in 2,480 school-going children 3 to 12 years of age during the time of May 1, 2021 till April 30, 2022. The children of age group 3 to 12 years who newly attended the clinic during the study period were included in our study. And those kids who had history of trauma, infections, corneal opacities or cataract, and those who were not willing for cycloplegic refraction were excluded. The details of the children were taken from the EMR, such as the age, sex, best corrected visual acuity, cycloplegic refraction, and the family history were taken, and the refractive errors were categorized into myopia, hypermetropia, and astigmatism. Coming to the result, out of the total 2,480 children who newly came to the clinic, 904 children were diagnosed to have refractive errors, which was 34% among the total. When the age was taken, the average age was 7.2 plus or minus 2.5 years, and the maximum refractive error was in the age group of 5 to 8 years. When the refractive errors were divided, astigmatism was the most common with 61.7%, followed by myopia, which was 34%, and hypermetropia, which was 4.3%. When the myopia was further categorized, it was moderate myopia, which was the most common with 54.1%. When the refractive errors were categorized according to the age, myopia was found to be more marked after 6 years of age, whereas hypermetropia in younger kids. When the astigmatism were further subdivided, majority was simple myopic astigmatism with 43.7%, followed by compound myopic astigmatism, which was 9.1%, followed by simple hypermetropic astigmatism. When the refractive errors in males and females were almost 1:1. Other ocular comorbidities such as amblyopia in 11.8%, squint in 16.6%, family history of refractive errors in 3.9%, and 2.5% of the kids were preterm. Coming to the discussion. In our study, it was found that 1/3 of the children who newly attended the OPD had refractive errors, among which 61.7% was due to astigmatism, 34% was myopia, and 4.3% hypermetropia. And the average age was 7.2 plus or minus 2.5 years, and nearly equal preponderance for male and female. In a study done by M.O. Ogulahi et al., the total refractive errors was 34.6%, mean age was 10.58, male to female ratio was 1:2, the myopia was 23.2%, simple myopic astigmatism was 21.9%, and compound myopic 20.8%. In another study done by Charavade et al., the prevalence of refractive errors was 16.4%. The overall prevalence was higher among older children with female preponderance, and myopia was most common with 83.5%, followed by astigmatism and hypermetropia. In another study done by Lian Hong Pai et al., the prevalence of hyperopia, myopia, and astigmatism were 3.26, 13.75, and 3.75 respectively. And another study done by Sethu Sheila Devi, population-based prevalence of myopia, hyperopia, and astigmatism were 5.3, 4, and 5.4% respectively. The limitations of our study is its retrospective nature and a small sample size, as it was a hospital-based study and only new cases were taken. Now the conclusion, Our study shows the high prevalence of refractive errors, high prevalence of refractive errors in school-going children in South Kerala, which is a major public health issue. So more screening programs and interventions should be implemented. And there should be also a creation of awareness of healthy lifestyles and habits. My references. Thank you.
Very good presentation. I have one question. See, in your particular study, there's a very high incidence of astigmatism.
Yes.
As compared to all the other studies, you had a very high, around 70%.
Yes.
So how do you explain that?
Sir, we didn't take the old cases which came to our OPD. Only new cases were taken. So,
No, but still, 70% of astigmatism is very high. So you also said that because of increased screen time and all that. But
yes.
what do you think? Why is the astigmatism more important in these patients, in these kids?
maybe due to COVID, because it was COVID times, there more strain, eye strain and all.
Okay.
And we only took the new cases which came to our OPD. The old cases were not considered.
And you feel that there can be a geographic change, because you specifically said Kerala. So if you take it in Karnataka or any other place, do you feel that it will change?
Yes, maybe.
Good afternoon all. The topic of my study is a study of functional outcome of children who were screened for retinopathy of prematurity. One blind child is a tragedy, whereas a million blind children, statistic. So, retinopathy of prematurity is the main ocular problem of premature infants during their neonatal period. Retinopathy of prematurity is an incomplete vascularization of retina, which is mainly attributed to an oxygen-induced damage. While later in their life, strabismus, amblyopia, refractive errors, and visual impairment came into play. So, the aim of my study was to determine the functional outcome of preterm infants based on their refractive status, fixation behavior, and also to analyze the risk factors for amblyopia. So it was a hospital-based cross-sectional analytical study done in children with 6 to 8 years of age who were born prematurely and who have undergone ROP screening during the year 2012 to 14. I did a sample random sampling, and the sample size was calculated statistically using the formula 3 PQ by D square derived from my parent study. So after receiving consent from the patients and also parents and taking assent from the children, I used a standardized performer to derive socio-demographic details and past treatment history. And then the best corrected visual acuity was measured with the help of Snellen's visual acuity chart, and a detailed ocular examination was done with slit lamp biomicroscopy and indirect ophthalmoscope. So, children who were born at a gestational age less than 34 weeks and are all with birth weight lower than 1,750 grams, and those with no other systemic diseases, and those with a refractive media, clear refractive media whom retinoscope is feasible, and those with no eye diseases except for ROP was included in my study, whereas those with an incomplete information and non-cooperative children, and those with family history of high myopia, and those children who were diagnosed with stage 4 or 5 ROP were excluded. So I've studied visual acuity, cycloplegic refraction for assessing the refractive status, and amblyopia was diagnosed according to the criteria given by American Academy of Ophthalmologists, and also the fixation behavior was studied. So my results, out of my 61 children, 61 had no ROP, and 28% had type 1, 8% had type 2, and 3% had aggressive posterior ROP. Simple myopic astigmatism was found to be the major refractive error with 31.1%, followed by compound myopic astigmatism, myopia, and hypermetropia. Strabismus was found in, exotropia was found in 24.6 and ESO in 9.8%. 77% of them had amblyopia. And I also studied association between refractive error and amblyopia, and a statistically significant correlation should be made out between amblyopia and refractive error, whereas no such association could be found out between strabismus, and amblyopia. Also, there was a statistically significant relation between the presence of ROP and refractive error. Also, association could be drawn out between the severity of ROP and refractive error. So, in my study, simple myopic astigmatism was found to be the major refractive error, and I could see that refractive error was the major risk factor for the development of amblyopia, and the risk of refractive error increased with the severity of ROP. A study by Hallstrom et al. Followed 248 infants for 3.5 years, and they also found an increased incidence of myopia, astigmatism, anisometropia, and strabismus. And according to a study by Wang et al., premature babies with or without ROP are susceptible to myopia and astigmatism. And Chen et al. In 2010, with 108 subjects, showed a higher prevalence of myopia, hyperopia, and astigmatism in premature infants. And another study showed that there is statistically significant association between anisometropia and amblyopia. So my conclusion is, the premature babies have significantly higher rates of refractive errors and amblyopia, and strabismus is also at a higher rate among these children, and therefore a regular and long-term follow-up of these babies is important for early detection as well as treatment of these ocular problems. And my study was also aimed at highlighting the need for an amblyopia screening in school-going children. The limitation was most of these children included in the study were under our follow-up, so may not be directly applicable to the general population. So these were my references. Thank you.
So how many of your 61 children had ROP?
61% had ROP, sir.
Okay. And how many of them received laser?
Those with type 2 ROP and AP ROP received laser treatment, sir.
So how many among these 61?
Among the 61...
Okay. And how did they compare? Was laser a higher risk?
Actually, I did a statistical analysis, but I couldn't draw any statistical significance between this laser and refractive errors. So.
Okay. Between ROP and premature children without ROP, was there a significant difference?
So
those with ROP versus those without ROP, was there a difference in the refractive error and amblyopia?
Yeah, those with ROP had a higher rate for refractive error as well as amblyopia.
Okay. So that is the message that you want to give. Okay.
Good afternoon. The topic for paper presentation is clinical study of etiological pattern and clinical features of uveitis in the pediatric age group. Why pediatric uveitis is special? Pediatric uveitis, even though having less incidence, differ from adult onset uveitis and is a topic of special interest because of its diagnostic and therapeutic challenges. The delay in diagnosis, high ocular morbidity, risk of amblyopia, and they are more prone to develop sight-threatening complications. Uveitis is responsible for approximately 20% of blindness worldwide, and the prevalence in developing countries are more compared to developed countries, and the prevalence is about 5 to 10-fold lower in children than in adults. The aim of my study is to study the etiological pattern of pediatric uveitis and to study the clinical features. Materials and methodology. The study design was a hospital-based cross-sectional study done in Tertiary Eye Care Hospital, Trivandrum, and all the uveitic patients presented to our hospital of age less than or equal to 17 were taken, and the study period was 1 year, and the sampling technique was consecutive sampling. The inclusion criteria. Age less than or equal to 17 years at the time of diagnosis. Exclusion criteria, excluded if they had any post-operative complication, post-surgical inflammation, or ocular trauma. The sample size was calculated to be 21 according to the previous yearly presentations. The methodology, that participants who met the inclusion criteria were consecutively recruited in the study till the required sample size is obtained, which was followed by a clinical history, including age, gender, place of residence, history of exposure to risk factors, followed by a uveitic ocular examination. The history was followed by ocular examination, including the best corrected visual acuity, intraocular pressure by non-contact tonometry, ocular motility, slit lamp biomicroscopy, and indirect ophthalmoscopy. And the data analysis was done using SSPS software. The study results I have got, there was no particular gender preponderance found. Male and female groups contributed almost equal. Then in laterality, about 76% were unilateral and bilateral contributed 23%. Pathology, majority of cases were non-granulomatous, about 71%, and 28% were granulomatous. Course of the disease, most of them had an acute onset, that is 66.67%, followed by chronic 23% and recurrent 9%. And this is the etiological classification. Majority of them were infectious causes, about 42.86%, and the idiopathic and non-infectious causes contributed to 28.57%. Then the etiological diagnosis, a major proportion was found to be infectious causes, and among them it included toxoplasmosis, tuberculosis, viral, and a single case of DUSN was have got. Then majority of non-infectious cause was juvenile rheumatoid arthritis, 5 cases, and in that 2 cases presented as band keratopathy, the first presentation itself, which shows the presentation of juvenile rheumatoid arthritis as white uveitis. The location of disease, anterior uveitis contributed a major portion, followed by posterior, intermediate, and pan uveitis. Discussion. In my study, there was no gender preponderance found. Most cases were unilateral, majority were non-granulomatous. Most of them had an acute onset, and etiology-wise, infectious cause was contributed a major portion, and anterior uveitis was most common. And in the study done by Narayana et al., there also most cases were unilateral, but in the study, anterior, intermediate, and posterior uveitis was seen in equal numbers, and infectious causes were most common. And another study done by Ratnam et al. Found to be anterior uveitis was most common and infectious causes contributed a major portion. These two were studies done in developing countries, and it shown infectious etiology was more common there. And another 2 studies by Tutkun et al. Found uveitis associated with non-infectious, and among them juvenile rheumatoid arthritis was more common, followed by idiopathic uveitis. And another study by Kum et al. Found etiology was mostly non-infectious, and non-granulomatous presentation was more, and laterality, bilateral presentation was more common. The conclusion is that in my study, anterior uveitis was most common, followed by posterior, intermediate, pan uveitis. Infectious etiology was more than non-infectious, and among the infectious cause, toxo, tuberculosis were more common, and among non-infectious, juvenile rheumatoid arthritis was common. And some children were diagnosed to have uveitis as part of routine ocular examination in patients like with juvenile rheumatoid arthritis. And young children are often asymptomatic, either because of their inability to express the complaints or because of a truly asymptomatic nature of their disease. And in some cases of advanced cases, parents may not be aware of severe visual impairment until the development of externally visible changes such as band keratopathy, strabismus, or leukocoria. So early and correct diagnosis, efficient management of uveitis in children is mandatory. These are my references. Thank you.
A good presentation. Thing is, yours is a retrospective study or a prospective study?
Prospective. You say cross-sectional study.
But what does literature state as the common causes for uveitis in children?
Juvenile rheumatoid arthritis was more commonly found in developed countries, sir. And in developing countries like ours, infectious causes were found to be more common.
So yours was a descriptive cross-sectional study, isn't it? And why did you have to fix your sample size?
According to previous records in the presentation of our hospital, study duration was 1 year, sir. According to previous records, I have calculated like that. In 1 year, about presentation was almost 16-20 cases.
Yeah, but so what if you had got 50?
Yes, I got only this much, sir.
Yeah, so it was not that that number was not important at all. No, only the time period was important.
Yes, sir.
It wouldn't have made any difference to you,
Okay,
to your study.
Thank you.
Good evening. My topic of presentation is incidence of macular edema following cataract surgery among diabetic patients in a tertiary care center. And cataract is the leading global cause of blindness, and cataract surgery is one of the most common operations performed worldwide. Cystoid macular edema remains the most frequent postoperative complication to result in impaired vision. A higher incidence of macular edema after cataract surgery is reported to occur in eyes with diabetes, and worsening often occurs after surgery in eyes with pre-existing diabetic macular edema. With the availability of OCT, that is optical coherence tomography, we can obtain qualitative and quantitative parameters of macula better and explore the relationship of macular status before and after cataract surgery in diabetic patients. Objectives are: primary objective being incidence of macular edema following cataract surgery among diabetic patients, and the secondary objectives are to correlate the changes in macular thickness following cataract surgery with preoperative HbA1c level, and to analyze the morphological patterns of macular edema following cataract surgery in diabetic patients. And the study design, it is a hospital-based, prospective, non-comparative observational study in patients attending ophthalmology or OPD of Government TD Medical College, Alappuzha. And the inclusion criteria: patients with type 2 diabetes mellitus undergoing cataract surgery for whom preoperative OCT is possible. And the exclusion criteria: patients with macular edema due to diabetes or any other cause who has taken intravitreal injection within 3 months of surgery, patients with any other macular pathology, patients with intraoperative cataract surgery complication, those who are not willing. And the study method: sample size calculated using this formula and found to be 29. Variables used in the study includes visual acuity by Snellen and chart, OCT, and HbA1c 2 weeks prior to surgery. Macular thickness will be analyzed with Cirrus HD OCT machine based on the 6 into 6 mm data cube captured by the macula cube 512 into 128, and the central subfield normal range 220.5 into to 294.8 microns. Fundus and central foveal thickness will be assessed at 1 and 3 months during follow-up. Independent t-test was used to compare qualitative parameters between categories. For all statistical interpretations, p less than 0.05 was considered the threshold for statistical significance, and the analysis was done by SPSS version 20. And the results: mean age group was 63.9 plus or minus 7.2, and the distribution according to duration of diabetes: 41.4 patients had duration more than 10 years, and according to diabetic retinopathy, 41.4 patients had pre-existing diabetic retinopathy, and according to HbA1c, 55.2 were uncontrolled diabetes, that is HbA1c more than 7. And discussion: 41.4% had macular edema with 24.1% cystoid pattern, 10.3 spongiform, and 6.9 mixed. CFT in diabetic eyes with retinopathy increased by 43.9 plus or minus 39.7 at 1 month postoperatively, which was greater when compared with eyes without diabetic retinopathy. And CFT in diabetic eyes with a duration more than 10 years increased by 43.6 plus or minus 39.4 at 1 month postoperatively, which was greater when compared with eyes with a duration less than 10 years. CFT in uncontrolled diabetic eyes, that is more than 7 HbA1c, increased by 35.1 plus or minus 34.1 at 1 month postoperatively, which was greater when compared with eyes controlled diabetes. Decrease in CFT from 1 month to 3 month posto was greater in controlled diabetes when compared to uncontrolled diabetes. As expected, there were significant improvements in BCVA at all post-operative examination time periods, with 1 line improvement from 1 month to 3 months post-operatively. And the conclusion being, post-operatively, CFT increased in all diabetic patients, with greater increase found in patients with pre-existing diabetic retinopathy, with uncontrolled diabetes, and with diabetes duration more than 10 years. And the limitation being small sample size. And these are my references. Thank you.
A couple of questions from my side. Thing is, what was the duration between the surgery and the onset of diabetic macular edema?
I followed the case at 1 month,
Okay.
then at 3 months.
Okay. So the thing is, my second question is, how did you differentiate your diabetic macular edema versus other causes like cystoid macular edema?
Sorry, sir. The range was CFT range was 220 to 294. Anything more than 294 considered as macular edema, and the cystoid spaces by analyzing the OCT pattern. That by analysis.
Did you exclude those with cystoid spaces or they were included?
Actually, they were included, but intravitreal injections were not given within 3 months of surgery.
Yes, no. So, sir's question is, how do you know whether it is a diabetic macular edema
yes, sir.
or a cystoid macular edema
due-
following cataracts? So, you just included all of them.
All of them, sir.
So, you could use the term pseudophakic
Fake
macular
macular
edema.
edema.
You're not committing to either.
Either. Okay, sir.
My study is choroidal vascularity index in diabetic macular edema. I have no financial disclosures. So diabetic macular edema is a leading cause for global visual impairment, and its pathogens is evoked by various inflammatory and vascular changes in the posterior segment. Choroid, as we know, is the vascular coat of the posterior segment, and a part of macula is entirely dependent on choroid for its nutrition. Thus comes the importance of choroid in diabetic macular edema. And previous studies have already demonstrated various changes in the choroid, and choroidal vascularity index is now being introduced as a novel marker of the choroidal health, and it is actually a proportion of luminal choroidal area to the total choroidal area. And the aim of our study was to compare the choroidal vascularity index among diabetic retinopathy patients with diabetic macular edema and without diabetic macular edema, and also to find the influence of choroidal vascularity index on various retinal and choroidal OCT biomarkers in diabetic macular edema. We included, ours was a cross-sectional comparative study, and we included 103 treatment-naive cases of diabetic macular edema and 100 treatment-naive cases of diabetic retinopathy without diabetic macular edema. And we excluded all those cases who had a previous history of ocular treatment or any other retinal diseases other than diabetic macular edema or any ocular condition which could impair the choroid. All patients underwent a detailed ophthalmic evaluation, including the EDI OCT imaging, and all of them were classified based on the ETDRS classification to different grades of diabetic retinopathy and different types of macular edema, and the cystoid, spongiform, and the submacular detachment type of diabetic macular edema was included in our study. For calculating the choroidal vascularity index, the EDI OCT images were exported into the ImageI software, where it was binarized so that the subfoveal white areas represented the stromal choroidal area, and the black areas represented the luminal choroidal area, and a 3000 micrometer central subfoveal area was selected with the polygon tool, and the luminal choroidal area percentage, which is the choroidal vascularity index, was calculated. All the OCT images were also analyzed for the number of retinal and choroidal hyperreflective foci, and also the outer retinal changes like ELM, ellipsoid zone, and RPE disruption, and all these data were statistically analyzed. Now to the results. The choroidal vascularity index among our diabetic macular edema patient was 65.98%, and those without diabetic macular edema was 65.25%, which did not differ significantly. And also, the choroidal vascularity index did not differ significantly among our different types of diabetic macular edema, and also it was not influenced by different grades of diabetic retinopathy. On comparing the number of choroidal and retinal hyperreflective foci with choroidal vascularity index also, no significant association was found. And the outer retinal factors like ellipsoid zone disruption, ELM, and RP disruption was also not influenced by the choroidal vascularity index. Now to the discussion. Chanda Gupta et al. From their study found that the choroidal vascularity index decreases in the presence of diabetic macular edema. But controversing, the Nicolini et al. Found that it increases with the development of diabetic macular edema. And Mirani Kim et al. From their study found the presence of diabetic macular edema did not cause any change in choroidal vascularity index in the diabetic retinopathy patient, and similar finding was also found by us. On studying the different grades of diabetic retinopathy, Mirani Kim et al., Kara et al., and Nicolini et al. Found that the CVI decreases with the progression of diabetic retinopathy, but no such association was found by us. So all these authors propose that the size and density of the choroidal vessels and the choroidal blood flow decreases with the development of diabetic retinopathy and with the progression of disease, but no such association was found by us. This may be because all our patients were diabetic retinopathy patients, and we propose that the choroidal vascular changes will also cause stromal changes like hypoxia and ischemia. So maybe the stromal to luminal area will be a constant in all these diabetic retinopathy patients. On comparing the choroidal vascularity index on different OCT biomarkers, no significant association was found by us, and similar findings were also found by Chanda Gupta et al. So ours was a small population study, and the majority included non-proliferative diabetic retinopathy, and it was a cross-sectional study in which only the images and the data in the initial visit was analyzed. So a change in the CVI with the development of diabetic retinopathy or its progression or with the development of diabetic macular edema could not be proposed. So a longitudinal study which analyzes the pre-diabetic retinopathy changes in the choroid and retina will give better information. And choroid being a highly vascular structure will be definitely be influenced by vascular disease like diabetic retinopathy. So a higher population study will give better results and inferences. So to conclude, the severity of diabetic retinopathy is not influencing the choroidal vascularity index, and choroidal vascularity index is not found to influence the presence of diabetic macular edema or the type of diabetic macular edema, nor is it found to affect the outer retinal and choroidal changes in diabetic retinopathy and diabetic macular edema. These are my references. Thank you.
Good presentation. Thing is, this index which you spoke about, can you quantify it as well? This index that you spoke about, this choroidal index that you spoke.
Yeah,
Can you quantify it as mild, moderate, severe based on the values?
No, sir. We didn't quantify because all our data were within 60 to 70%.
Okay.
No previous studies haven't quantified it like that.
So you didn't quantify it.
No, sir.
And how is this going to help in your decision making for treatment compared to OCT versus this particular index that you have got? How is it going to help in your treatment?
Maybe we could predict the development of, based on the changes, we could predict the progression of the disease, and likewise measures could be taken. So we could control the disease if we get better insights into the involvement of choroid in the disease.
No, because you said there are mixed reports between diabetic retinopathy and this. So
Yeah,
this
the
was asked.
study population is also differing in these studies. Okay, thank you.